Welcome to osTEAo, that's with a capital TEA, where osteo warriors and treatment and recent survivors spill the tea on all things osteosarcoma and cancer from the adolescent, young adult patient perspective. Listen in on our honest and personal conversations about our osteo experiences, stories, and who knows what else. We tend to go off script, so you never know.
Me trying to figure out which screen I can read off of. Okay, this podcast discusses all aspects of the young adult cancer experience in a conversational format. In today's episode, we will be hosting a Q&A with Dr. Kurt Weiss, an osteosarcoma survivor and orthopedic surgeon and oncologist. Our conversation will be appropriate for young adults and up. Audience discretion is advised, especially because I'm here. Like and follow MIB agents on social media for all the intel.
All the hot goss. It's on our socials. For anyone who's in the Houston area, MIB will be heading your way this month. Join us on November 30th from 5 to 7 p.m. for an MIB mingle at the Blossom Hotel, which is right next to MD Anderson. Everyone in the osteosarcoma community is invited. Please email events@mibagents.org for more information. So welcome everyone to the 6th episode of osTEAo. I can't believe we've already made it to 6 episodes, the Osteosarcoma podcast. If this is your first time tuning in to osTEAo, my name is Mia. I'm an OsteoWarrior and the Vice President of the MIB Junior Advisory Board. To give a brief background on me, I was diagnosed with osteo back in 2018 when I was only 19 years old. I went through MAP chemotherapy for 9 months and had a limb salvage surgery on my right tibia. I have since named him Rodney. We have a love-hate relationship. I relapsed about 8 months after finishing MAP with metastases in both lungs. I've tried multiple other chemo regimens and an immunotherapy treatment. I've also had 2 thoracotomies and upwards of 20 cryogenic and radiofrequency ablations for metastases on multiple bones and in my lungs. Of course, with us today is our lovely guest host and icon, my mother, Serena Sandino.
Yay!
Pleasure to be here. Hi, everyone. I'm Mia's mom and a proud supporter of MIB. Today, I'm honored to introduce Dr. Kurt Weiss. We're thrilled that you're here to chat with us today. Dr. Weiss, can you tell us a bit about yourself and your connection to MIB?
Yeah, sure. Can you guys hear me okay?
Yeah, we can hear you just great.
Okay. Well, so I'm a osteosarcoma survivor, an osteosarcoma surgeon, and an osteosarcoma scientist. So I wear a lot of hats.
That is a lot of hats.
And I was the very proud recipient of an outsmarting osteosarcoma grant. Rather, no, that's not accurate. Our lab was a very proud recipient of outsmarting osteosarcoma grant from MIB. It's never about me, it's about the team. And we were very, very fortunate to host. You guys roll heavy, I noticed that. We had no fewer than 14 osteosarcoma warriors and their families come in to see the lab and give us the award in person in August last year. And it was pretty wonderful. And that's how I was sort of introduced into the MIB community, and MIB does things differently.
Yeah,
I won't, although I maybe could say it's better, but it's certainly different. And I really, really like the way MIB does business from top to bottom. And I'm just super, super grateful to be now part of the family, and I think it's terrific. I think you're terrific, and that's how I get to be here. I got sick when I was 15 years old, so younger than you, Mia. I was a freshman in high school when I got sick with osteosarcoma in the top part of my tibia, what we call the proximal tibia, by the
same place.
And I started out with a limb spare, and that failed. Then I had another subsequent limb spares, and after a couple dozen operations and a bunch of other interventions, I said, you know what, I'm not doing this anymore. and I need to get on with my life rather than being in the operating room every 3 months. So I ended up having a amputation from above the knee when I was 22. So you got to be a real stubborn ass to fight a bone infection for years, but that's what I did. And so here I am, and that's the quick of the story.
Well, I know the community is going to be curious based on what you just said. So I'm going
Yeah.
off for a minute and I'm going to ask a question.
Please.
My question is, what caused the limb salvage to not be effective for you? Were there
Great
surgical
question.
complications? Were there infections? Because people think, oh, I can have this and everything's going to be great.
Right.
So tell us a little bit more about that, please.
So you actually already hit it, Serena. I got an infection. No, so that isn't actually the first thing. So I started out with what's called an allograft, an osteoarticular allograft, meaning that it replaced half of my tibia and part of my knee joint with a piece of cadaver bone. And the idea is that bone cells, and we said we weren't going to geek it up, but I am for just a second. Bone cells that are very sensitive to geometry. They're kind of like hermit crabs. Like you present them with something that looks like their home and they say, oh, I should move in here. And so that's the idea of an allograft, that if you put a dead hunk of bone next to living bone, the living bone will eventually populate it and move in there and make it into a normal bone. It's a great theory, doesn't always work. The allograft didn't unite. And I was pounding on this thing pretty good. So after several months, the plate holding the host bone, so the part of me down by my ankle to the part of me down by my knee, that plate broke. So I had to have a revision surgery, so a do-over. And in that revision surgery, I got an infection, and it just never left. And we tried a bunch of different operations and plastic surgery and antibiotics, and it just wouldn't leave. So that's when we decided to do the amputation surgery.
Gotcha. It's crazy how many complications there can be, even still today. I already think that we're going to be having a very interesting and informative episode today, and I'm really excited. Thank you for joining us today. And we cannot fully get started with osteo without our first segment of the episode. What's the tea? Like,
What's the tea?
Literally, we'll be going around and sharing what we're drinking today and giving an honest review. And I will start it off. So I am drinking out of my dinosaur mug, which was a gift from a very close family friend. Love dinosaurs. I think they're hysterical. Also, the first known osteosarcoma case wasn't a dinosaur. So go figure.
True statement.
I am drinking something that my mom made for me. So I'm not entirely sure what it is, but it is quite delicious and refreshing.
Should I spill the tea
I
on what it is?
Yes.
Today, Mia is drinking some Empress gin mixed with club soda. Empress gin is purple, which is one of Mia's favorite colors.
It is. I wish you could tell in this mug, but it is very beautiful.
And we've had a difficult few weeks in terms of the osteosarcoma world.
Yes.
So I too am drinking something that is not tea.
Normally we drink tea.
Normally we do.
But it's been
But
a
today
difficult
we're not.
Not today.
Here's to that. But today I'm having a 2019 Chardonnay from California, our home
Ooh.
state.
I would review my drink as delicious, and personal reflection of who I am. And I appreciate it greatly. And it was made with love.
It was absolutely made with love. I would consider mine to be a little fruity and maybe not as chilled as I'd like.
Okay.
And what are you drinking?
Fair. So I feel a little bit underdressed, at least from a beverage standpoint, but mug. This is my green Notre Dame tea that my daughter Anna made this for me at camp. So thank you, Anna.
It's a beautiful mug.
It is.
Thank you. I will tell her you said that.
Yep,
And
she did a great job.
I am presently drinking the very stylish and exquisite Allegheny River water from that hospital.
It's a great vintage.
Yes.
Yes, I do have, but I do have some other non-tea beverages, which perhaps I will treat myself to later when I'm done working.
That
Good idea.
sounds like a great idea. Perhaps it could be a tea colored beverage.
Yes.
It will absolutely be a tea-colored beverage.
I know that Mia's oncologist likes the, how did you describe it in your speech?
Dark liquor.
Dark liquors. Yes, he likes.
I call it brown water.
Yes.
Same thing.
Yeah, normally I would be actually drinking tea, and I drink plenty of water. There are no problems here, even though alcohol technically is a solution if we're getting technical. So we have some great questions that have come in from the MIB community, which is definitely awesome. As you said, we roll heavy, we roll in together. So there's a question that came in from our community. As a cancer survivor, now doctor and researcher, what is something that you wish you had during treatment that patients nowadays have access to?
Yeah, so that's actually pretty easy. Zofran hadn't been invented yet.
Oh,
wow.
God.
So yeah.
That's heavy.
So when I started getting treatment in 1989, the antiemetics we had was called Thorazine. Now go ahead and look that up. That is it basically just knocks you out. It's a sedative. So
Get me nauseated in your sleep.
the thought was you can't be sick to your stomach if you are unconscious. So, we just didn't have anything better, and then you'd wake up and be sick all over the place and get more medicine and go to sleep. It wasn't great. It's still, but I believe that Zofran and Phenergan are probably better weapons than what we had against the side effects of the nausea and vomiting from MAP chemotherapy. That's the first thing that comes to mind, actually, in terms of like medications and drugs and supportive things. Also, we were you mentioned that you had some thoracic surgery.
Yes.
VATS hadn't been invented yet. So, the little thoracoscopic procedures through the little incisions, we didn't have that. So if you wanted chest surgery for osteosarcoma, well, nobody wants chest surgery for osteosarcoma.
Nobody wants it.
For God's sakes.
He wanted it twice.
If you had to have it, which I've had twice, you had twice, you had to get, like, I have this lovely guy right here.
Oh, so you had a what's it
You had
called?
to get your chest cracked and open it up, and I got another one over here. So maybe my surgeons could have done the little keyhole operations, maybe not, but it would have been nice to have that discussion. Those are the two things I think of.
Yeah.
You didn't have keyhole.
No, I didn't.
Mia looks like her scars are like somebody removed angel wings.
Yeah, I have the true, crack through the ribs,
Oh wow.
spread them, that whole, yeah. I had 2 of those back in March of 2020. Great
Yeah.
time.
Timing was not
Perfect.
good.
What are you
The
talking
beginning
about?
of
It's perfect
beginning
of
of the
COVID.
pandemic, hospitals didn't know what to do, wanted to clear people out. First day, the first procedure, she had like 9 days in the hospital with liberal pain meds. It was hard to get over the thoracotomy. And then it was supposed to be 3 weeks apart. And they called you back when?
Like 11 hours before I was supposed to be at the hospital for the surgery.
But how many days later?
I believe it was exactly 3 weeks.
I think
yeah.
it's less.
It was somewhere in the ballpark of 3 weeks. It might have been less, but they moved it up by at least 4 weeks.
Some
Because they
thing,
didn't know what was
to
going
do.
on with COVID. So they moved up my procedure date and only gave me 11 hours notice. They called me at about 6:30 p.m. and told me that I had to be there at 5:30 a.m. for pre-op.
Hey, what
That
you
might have
doing?
been when I started drinking wine out of teacups. I'm not sure.
Oh,
But
yeah.
it might have been. I'm not really
The
Not
pandemic
really
has
sure.
changed many a thing.
But they had her leave the hospital after 5 days because
Yeah.
COVID had really started to
Hit UCLA.
ramp up, and I think they just wanted to protect her. But it was 5 days post thoracotomy.
No
and just trying
epidural,
to
just oral
manage
pain meds.
oral pain meds was
Yeah.
really,
Yeah.
really intense.
Yeah. I would say
Yeah.
April 2020 was one of the worst months of my life. That's for sure. So thank you for sharing all of that with us. I know that surgeries are barbaric in so many ways, even more so back in 1989 when you started, your procedures. And it's just crazy that there have been advancements, but still the answer is either amputation or limb salvage when it comes to the initial response. I know that there are some other techniques that are kind of popping up as we saw at Factor. But it's still kind of a slow moving evolution of techniques. But yeah. There's another question that came in, but I feel like we covered most of it. And it's in the same topic. So this is on the topic of surgical options for osteosarcoma.
Yeah.
What are some important considerations when deciding on a limb salvage or a rotation plasty or amputation from your perspective?
From my perspective, as someone who doesn't do a ton of rotation plasties, it's age and size. So I like the expandable megas, the so-called growing prostheses. But there is no question that on a rotation plasty, although it is a type of amputation, you can pound on that as much as you want. And they are, when they work, man, they are fantastic. And kids do such amazing things on rotation plasties. They're durable. Yeah, kind of amputation. That's true. But man, you never have to worry about, geez, am I wearing out my prosthesis? Like, who cares? You get a new one.
Yeah.
So it's this, right? It's
Yeah.
One size fits one. You got to size up the kid and the family, and certainly the size of the patient, the location of the tumor. All these things are important, but this is one of the challenges in what we do is there's no cookie cutter answer, right? You have to put all these things together and try to do the best for the person who's right across from you, which, osteosarcoma is not osteosarcoma, is not osteosarcoma. And, Mia and Kurt are not the same, and they need to be treated as such, right?
When Mia she had her limb salvage surgery, I got online with some osteosarcoma groups, and I had no idea what a rotation plasty was. And as a mom who'd never heard of one, randomly looking it up, it was like, and I believe I was like, and then, but seeing exactly what you said, what kids can do who've had these, it's absolutely phenomenal. But I do feel like a lot being an osteo mom is being like, so
it's a whole new world, if you will.
They're not for everybody.
A world I never thought we'd be part of.
Yeah.
They're not for everybody. Limb sparing is not for everybody, right? It's got to be a one size fits one preposition.
Agreed. Could not agree more. Again, apologies for Mateo. He has no thoughts behind those beautiful big green eyes of his.
Yeah.
But he is a sweetheart, and he actually, we got him because I knew that my cancer had spread to my lungs, and I knew that I had power and could ask for essentially anything I wanted.
Yes.
And the answer to that was another cat.
Yeah.
And so we ended up with the closest cat form of a himbo that we could get.
Do you know what a himbo is?
No.
Think Hercules from the Disney animated film Hercules. very good looking, strong, big, no thoughts. No
Like a
thoughts.
gym bro? Okay, you're describing, and I love him so much. You're describing my son. Yes.
Okay, perfect. Yes. This is what Mateo is. He's just big. He's very sweet.
Mhm.
Yes.
He's a very handsome boy. But again, no thoughts.
Yeah.
So, yeah.
The number of
His thoughts.
Mia has gotten since
Yeah.
diagnosis is staggering.
It's 3.
Mhm.
And saying that we already had 3 is that is my coping mechanism of choice, is just pouring all my love into these creatures who often do not want me to hold them. Most of the time they do, but sometimes they don't, and that hurts a little bit, I'm not gonna lie.
Yeah.
Um,
Thoughts. He just unfortunately he has the same level of common sense as his father, which is like so. God bless him. Comes by it honestly.
Were you concerned when you were a teenager about not being able to have children based on the chemotherapy you went
Great
through?
question.
Big time concerned. I didn't know if I was ever going to be a father, which is something that I really wanted. I remember talking with my family about this, and my brother Eric, who's 6 years older than me, said, you know, if I have to, I'll donate sperm so you can have a little Weiss baby,
That's really
which was very sweet.
Mhm.
Is sweet. It ended up not being the case. I think it's way easier for guys, you know, because just again, said we weren't going to geek it up. We're geeking it up. Males make sperm continuously from like 13 to 80.
Yeah.
Never stops. When women are born with the number of eggs they got, you got what you got, and that's it. So the whole fertility thing is a much harder, more difficult issue by and large for girls than it is for guys.
Yeah. And I remember right before I started MAP, they asked me if I wanted to freeze my eggs. And I had seen how much fertility science has evolved over, you know, the past, I'd say, 20-30 years, and decided not to, especially because it was going to be very expensive and there was a low chance insurance would have covered it. Now,
I
thankfully,
said, don't worry about the cost. If this is what you want to do, we will do this.
Sure.
And ultimately, it came down to Mia not wanting to put off her treatment
for
longer
another
to go through
month
the.
and a half, 2 months. Yeah. So it's a hard decision. So it's like there's
Yeah.
a chance that you might still have eggs afterwards, but you'd also have to delay treatment by 6 to 8 weeks, and that could be 6 to 8 weeks that determine your life at the same time. So it's always a very difficult toss-up.
Because it was only in her leg.
Yeah.
And there was nothing in her lungs when she started MAP. And her case was a little bit different because her needle biopsy made it seem like it was a giant cell tumor.
Yes,
So they
benign.
removed the tumor and said, hey, you know, but if something comes back,
We're going to go back in and
we'll
do
have to
salvage.
go back. Yeah.
So,
And a tiny part of the tumor.
was osteo.
Mhm.
And now here we are 4.5 years later. So
God, I wish it was 4.5. It's only 4.
it's closer. Let me live.
I'm letting
Let
you
me
live.
live.
I'm letting you live.
Not that cancer is, but anyway.
Yeah, the cancer is definitely being very, very difficult with Mia lately.
So speaking of survivorship, the transition from treatment to out of treatment is a very strange time. And I know that that's exactly what it says on the script,
Man.
but I feel like that's the perfect descriptor. It is
Yeah.
very odd and discombobulating. So did you have any mental health struggles personally, if you feel comfortable sharing that? And
No,
are
hey,
mental health struggles post-treatment common?
Mia, I'm so glad that you asked that, because as time goes by, I become more and more interested in this. And if I'm like rambling on too much, please just give me the hook. I so when I was, I probably should have been in therapy, like right from the beginning.
Mhm.
It just, not that, I mean, there was a stigma, but also it just wasn't a thing, right? There wasn't the awareness of mental health and like, geez, maybe you should talk to somebody and about these things, and the support. We weren't malicious, we were ignorant.
Yes.
We were ignorant, and we didn't know how to deal with these things. And so you're right, that time when of survivorship, like the chemo's over, the surgery's over, and now I got to put the pieces of a life back together, but the pieces are no longer the same size and shape. So how do I do that? Because I'm not the same. And that's hard.
Yeah.
And I've seen that struggle in 100% of my young cancer patients without fail. And you can help me, Mia, because I tell you, the best I can do is say, well, look at my patient and say, I see you going through this hard thing. And it's difficult, and you're mad and you're sad and you're entitled to all that. I see it. You're going to be okay. Time will help. Just stick with it. You're going to be okay. This is a hard time. Everybody goes through this. You're going to be all right. But that's the best I got.
Yeah.
And that's not much. At least in my estimation, it's not much. So like, how can I do better? Because I mean, you get it. You know, it's when the no more chemos are scheduled and no more surgeries are scheduled, you're like, well,
Now
okay,
what?
I am. And like
now
all
what
the-
should be just a t-shirt.
Yeah.
Cancer, now what?
all the doctors are like high-fiving each other and like, we're so great, blah, blah. And you're grateful, right? And you're happy, but it's not perfect. So like, what's going on? And it's hard. And I want some advice from you on how to shepherd people through that, because I don't think I'm doing an adequate job.
So there are a number of things that you can do on a personal level. Sometimes the most powerful words that you can say are just four words. That sucks. I'm sorry. Those can be some of the most powerful words, because sometimes when you are talking to someone and they just want to vent, they just want to let you know what their problems are. If you really care about that person, of course, naturally, the first thing that you want to do is give them as much advice as you can. But there are some cliches that come along with that, like, I'm always here to talk. I'm always here to help. And not that those are bad things to say, but they're relatively vague.
Mm-hmm.
So sometimes you just need to make the person feel heard. And whether that's by just saying, that sucks, I'm sorry, it's really hard, I'm sorry you're going through this. You can, it be like, are you in a place where you would like suggestions or just an ear? And in terms of resources, you can put them in contact with mental health professionals who are associated with your hospital. I feel like there's a lot of pediatric psychologists who really do well with the osteosarcoma age group. Like I'm still under pediatric care, even though I'm 23. I want my therapist job. That is my life goal. She is a clinical psychologist who works with AYA cancer patients and kids who are in undergoing treatment for eating disorders and the obesity clinic. And so that's kind of her domain. And so when you just, as a provider rather than personal, connecting your patients with the right resources afterwards, or even just suggesting therapy or support groups, there is safety in numbers. Even though everyone has a different story and a different outcome, nothing can help build that support like a social group of some kind, whether it be family, whether it be friends, whether it be.
But you got that through MIB.
Yeah, and I did get that.
She has so many. She's met so many different young adults at MIB and adults who have had similar experiences, or sometimes worse experiences, but it's like a safe place for them to be able to communicate with each other, which is why Mia and her peers wanted to start OsteAo, where they could talk about what
dating, relationships,
what it's like for them.
Q&As with people who have been through it, relationship expert. I mean, just we love having professional guests on like you. And it's just the difference between OsteAo and OsteoBites is that OsteAo is less science heavy. It's less research heavy. It is much more conversational. It is much more an open and welcoming space. Not that OsteoBites isn't, but a lot of the science can go over people's heads.
Well, can we play my favorite game?
Sure.
Sepsis or no sepsis? Have you had sepsis?
Oh, this is a great game.
Probably.
Yeah. Oh, that's an interesting answer.
Yeah, but the eye doesn't see what the mind doesn't know, and vice versa. I'm sure several of those times, if I had blood cultures, they would have been positive. Our treatment of infection has evolved a lot too over the last 30 years. So yeah, probably.
Yeah, I've had it twice. Once regular sepsis, not that any sepsis is regular, and the other was full-blown septic shock, lung collapse.
She couldn't breathe on her own.
Couldn't, on a vent for 6 days.
Well, she couldn't maintain her own blood pressure. Yeah, it was bad, and it came on really fast.
Yeah, I if I hadn't gotten to the hospital within, I think they said like a 3 or 4 hour window, I would have been dead.
I think that some cancer patients get annoyed when the moms are hovering with the thermometers, but we do it for a reason.
Yeah, she has saved my life so many times.
I was all over that. And that
absolutely 1,000,000%. It's really funny you say that's, well, it's not funny, Serena, because my mom always stayed with me in my treatments, and every single time there was at least one thing that happened where it was a damn good thing she was there.
Mm-hmm.
Without fail. And my nurses were awesome, and your nurses were awesome, but nobody's perfect, right? And it was, so I feel you for sure with the hovering with the thermometer.
I definitely did that.
My personal favorite, and I feel like any other AYA patients or survivors watching this may understand this. I cannot cough, I cannot sneeze, I cannot sniffle without are you crying? Are you okay? Is everything okay?
Mm-hmm.
If I'm tired multiple days in a row, do you need labs? And I'm like, nope, I think I just have depression, but thank you.
It's a fine line.
It is.
Being a cancer mom, especially to an adult cancer patient. It would be at 15, it would be more like, because I'm your mom and this is what we're doing. But now it's like, I respect your decision as being over 18, but here's what I feel.
Well, I got a German mom, so I may as well still be 15. It's fine.
Yeah.
It's great. It's great.
So I'm just beyond lucky that I love my mom, but more importantly, I like her. So that has made this much, much easier.
Here, cheers to our over 200 nights in the hospital.
Cheers. Yes, I love you too. We've spent a lot of time together, and in a weird way, it definitely has brought us closer.
Yeah.
Call it trauma bonding or just Stockholm syndrome, but I I adore her endlessly. and there's no one I'd rather spend that much time with in a hospital than her. Most of the time, sometimes it's just the ways to improve mental health are the small steps. Sometimes that's all you need. One of her favorite things to do was to bring me ridiculous balloons from the gift shop that had nothing to do with anything that was going on with me. So it wasn't like a get well soon. She comes in with like a 3-foot tall, it's a boy balloon while I'm undergoing like my 8th round of methotrexate or something ridiculous. It's a boy.
Just because it was so ridiculous. So it was Mia's 4-year anniversary since the day she was diagnosed.
Cancerversary.
It's called a cancerversary. And she wanted to celebrate it. And I'm thinking, okay, but sure. So once she says she wants to do it, I'm in. So we get these bundt cakes. We were away, but we people went and picked up like decorations for us, but they didn't understand. Like when I said it's a boy, like I wanted a balloon that said it's a boy just to make her laugh. They thought it was like a baby boy's shower.
Yeah.
So all the little bundt cakes came on an it's a boy plate. And just this it made no sense. No one were asking me about going for decorations. I mean,
there
everything.
was
we thought
was there. There was a whole lot that happened at this event.
Yeah, we were at a spa and people were like, wait, you're eating cake, you're drinking champagne, we're inviting people over for a party, and they're like, what's the party for?
And I'm like, I still have cancer, but I made it 4 years for a cancer at, stage 3 osteo. Once it metastasizes to the lungs, the mortality rate, as you know, or the survivorship rate drops to 27% nationally.
Would you agree with that statistic?
Yes, that actually is one of the questions that's on here.
So,
what do you believe is true in your opinion? This is not an official, as someone who is both a survivor and a provider.
It's probably around there someplace. I don't know if we're going to get an exact number, and I don't know if that's important. The important thing is that, we know what kills the patient, and it's not the disease in the arm or the leg, right? I got a great answer for that. What we need to do, the nut we got to crack is, what do we do when the cancer has left the arm and the leg and has found a home in the lungs? Only good thing about osteos, we know where it wants to go.
Yeah.
And that's the lungs. So what do we do about that? And for a percentage of kids, we get it right with the chemo, right? It's kind of like the 3 bears. Probably a bunch of kids were being overtreated, right? Probably some of the time we're getting it just about right. You do need pre-op chemo and you do need post-op chemo. But for people like you and me, we're not getting it right. If you're taking powerful medicines to keep a bad thing from happening, and the bad thing happens anyway, well, then the medicine isn't effective. And there's no way. What we need 2 big things that I would like to see. Big thing number 1 is something that specifically targets pulmonary metastases and that biology, okay, which is like basically all we do in my lab. And big thing number 2 is, how can we figure out who's who?
Yeah.
Who needs the full court press, 10 weeks of pre-op, big margins, 10 week of post-op, versus who can we give 2 cycles and we're done?
Yeah. Well, I would love it if one day in the future
we got
that is
like that.
Right?
What it is. I mean, that just brings tears to my eyes, because Mia's been through everything: MAP, ICE, Faradac, Velcade, Stivarga, OPDIVO, and nothing is doing what it's supposed to be doing.
And Cisplat and I did not get along. Not that Cisplat really gets along with most people, but I lost about 15% of my hearing after 1 dose. And I ended up with the worst acid reflux of my entire life. So much so that I thought that I was having some form of a heart attack. which I know can happen with doxorubicin. I know that it's cardiotoxic. So,
But she decided she
scary.
didn't want to wind up with hearing aids, which is what they thought was going to happen. If this is what happened on the first dose, the subsequent doses would have
yeah,
been worse. But that's where voicing her wants and needs was really important.
Yeah,
You know, it was, whoa, no, you know, I don't want to live the rest of my life with hearing aids if I can
avoid it.
avoid that.
And so they switched me to IFOS instead of the cisplat. So I guess it was not MAP.
But
which was my tie, but you know,
a lot of chemo with a lot of side effects. And I have to just bring it back around to MIB again, because that booklet that they send out with what to,
oh my God, it's incredible.
It's just a game changer. Like when I went into this, I didn't know what a charge nurse did or what a proximal tibia was, or all the language that was suddenly being hurled at us. And, you know, I graduated from college and I can Google just like everybody else, but it really made it so concise. And between that and open communication with healthcare providers, it's all I could say is anybody who's watching this podcast or listening to this podcast, voice your concerns, speak up, educate yourself with groups like MIB or any other group that you find. But
Facebook, not a source.
Although I found MIB through Facebook, so and I'm so happy I did.
Yes. But I totally appreciate everything you just said, and I completely agree. But I do just have to backtrack really quickly. I believe that the future of osteosarcoma treatment and Dr. Weiss, how to address the issue of how to figure out how to properly treat someone lies in genetic testing. And I think that we're only just starting to scratch the surface of full genome sequencing. Especially of the tumors themselves, not just healthy tissue. And I feel like once the tumor is out and, you know, things are being treated, you have to see what the mutations are and which drugs would be more effective. And that's a major issue that we've had, is that I have the PIK3CA mutation, which is extremely rare in osteosarcoma. It's only in about 2% of osteosarcoma cases. And so the drugs that they've tried with me haven't necessarily been effective. I've been on the more chemo-resistant side because of the mutations that my osteosarcoma specifically has. And of course, in my head right now, all that is happening is my sarcoma. And I know that it shouldn't be. my. Yeah. So my sarcoma is very different than many of my peers. So
cheers to research.
Yeah, cheers to research. And you guys are doing the hard work, the work that needs to be done, and we can't appreciate it enough is basically what I'm trying to say. But
now that you've been through this, I need to know. When you go, do you still need follow-up scans this many years post?
So I'm a terrible patient.
Shocking.
As doctors normally are,
like really, really bad. So I probably at this point, let's see, I finished my experimental treatment in the early days of 1991. So, 31 years. So at this point, I probably don't require any chest imaging, but it would not be stupid for me to get you mentioned earlier the cardiotoxicity of adriamycin. Doxorubicin, adriamycin, is bad for your heart. Bad. And so I should probably still be getting echoes every year, every couple of years.
Wait, maybe we could be saving his life right now.
You could.
Maybe you're gonna get a scan and be like, this is for Serena and Mia.
The last echo I got was not too terrifically long ago, and I'm doing okay. But heart failure in in childhood cancer survivors that have had adriamycin is it's pretty common, and that's bad. So if we could figure out something that was a little bit smarter than doxorubicin and a little bit more biologically effective, then yeah, let's just throw napalm on the tumor and kill all the quickly dividing cells along with all the other quickly dividing cells in your body. That would probably be a smart thing for us to do. That was a long answer to your question, but I probably don't need chest imaging anymore. I probably should get my heart checked out. I definitely need, you mentioned hearing. I'm driving my wife crazy. I need to get my hearing checked. It's gotten worse. I would be shocked if I didn't have hearing aids in 5 years. That's with that.
It's just kind of how all of these drugs, it's just how your body remembers them. It's like they hold on to the trauma, and it just has these super, super long lasting impacts. And I know that, going back to mental health very quickly, one of the big things that your patients feel, and that's something that I feel, and you might even feel too, is something that we like to call anxiety, which is anxiety scans. It's terrible. I hate it. It scares me every time, even if I know that there's probably not going to be anything too shocking. And it's of course when I get my hopes up that it is bad. So I just tend to lean into it with a sense of I'm a pessimistic optimist, where it's like, I think things are going to be okay, but I wouldn't be surprised if they're not, so it's like, you got to keep your expectations low. I feel like is my response to it. But how did you deal with it in the past, and how would you tell your patients to deal with anxiety?
Not well, probably, if I'm honest with you. It's the worst thing ever. I called it balancing on spit, because you feel fine. If you break your arm and you can see your arm's broken, you pretty much know what the x-ray is going to look like, right? With these chest scans, you can feel terrific. And some knucklehead can tell you got a little, 1 centimeter thing in your lungs, and your world is turned upside down again. So you can't base it on how you feel, which is terrifying.
Thank you for acknowledging that.
Yeah,
because I think a lot of people don't get that, and they're like, "But you seem healthy. You look good. It doesn't matter. You could have tumors growing in your lungs, and it's not like you're gonna cough or necessarily or show these signs that people expect you to show, and it's hard."
Yeah.
So I have a young lady who is now a sophomore or junior in high school, and I met her when she was 9, and she had an osteosarcoma from basically the top of her humerus to like this far from her elbow. Like, it was all tumor. It was terrible. And she had metastatic disease at the time of presentation. And, as we said, ain't good. So she got her chemo, and then, so what am I going to do to take out this arm tumor? Well, I could put a megaprosthesis in a 9-year-old, not crazy about that idea. It would be really nice to try and save as much of her humerus as we can, and keep the elbow that God gave her. So what we did was we removed the tumor. That was actually the easy part. And we harvested her. So this was her right arm. We harvested her left fibula bone. So we took 20 centimeters of fibula, which on a kid her age is like the whole fibula, and plugged it the cartilage of the fibula into the cartilage of her shoulder socket.
Wow.
And screwed that to like this much bone at her elbow with like, 1.5 screws and some prayer. And I mean,
I appreciate your honesty.
So truly a wing and a prayer.
it is, and it's
Wing
crazy.
and a prayer.
So her shoulder motion isn't awesome, but man, she plays clarinet.
Great.
And she survived, and she's amazing. And that's the
I love this story.
yeah. But I have to add that I did like a portion of this procedure. The real heroes of that were the plastic surgeons and the vascular surgeons and all the other people in there that were helping me out and making me look pretty smart. It was a team from start to finish surgically, and
How many hours was that surgery?
it was a day. It was like whatever, 10 hours, I think. But like the vascular surgeons, the microvascular people, the plastics people, everybody pitched in on that. And it was a real tour de force to surgery, and the craziest damn thing I ever did. But the proof is if the proof's in the pudding, it worked pretty good. So yeah.
That's really awesome. That is such a great story. Oh man. And it must be so heartwarming for you as well, because the fear of losing a limb and having had, sacrificed part of your body, that you were able to provide this 9-year-old the opportunity to live her life and play clarinet with her arm pretty much,
Yeah.
like with most of its function.
Yeah.
And that kind of ties into our next, and I've been having such a great time talking that I didn't even realize that we're pretty much out of time. So I'll
Don't worry about it. Let the editor. We should just talk.
they can choose what they want.
Yes.
So it ties into our last question. How would you say that being an osteosarcoma survivor changed your perspective on research as opposed to your colleagues who have not personally experienced it?
Okay, so great question. I want to say two things. Thing number one, we already talked about this. Presented with Mets, had progression of disease while on my postoperative chemo. So obviously, you don't need a master's degree in anything to understand that the chemo wasn't working. People say, oh, the patient failed chemo. Pardon my language, bullshit.
I agree.
Right? Okay, let's call it like it is. The chemo failed me. Didn't work. Yeah, not having any other good options, I did an experimental treatment at MD Anderson. You were talking about MD Anderson earlier and how there's an event there at the hotel. And what am I going to do? Take more chemo that didn't work the first time? So I participated in an experimental treatment, and then the craziest thing happened. It worked. So for me, Mia, I learned from a very young age that osteosarcoma research saves lives. Period. Full stop. End of story. That is not something that I tell the people in my lab to make them feel better. It is not something I tell parents to make them feel better. That is the truth, and that is my experience I live with every day. But and that's a good segue to the second point I want to make, which is that you know what really inspires me is people. Your cat's name is Mateo. I also have a buddy named Mateo who's an oncologist at Cleveland Clinic.
Mateo Trucco.
Yeah, and him and my partners here at Pitt, Stella Lee, Missy Burgess, Ben Masev, Kelly Bailey, like these people, I'm supposed to be passionate about this stuff, right? I'm supposed to be into it and like fighting for it, tooth and nail, hook and claw the whole way. that is understandable. To me, that's not at all inspiring because I'm supposed to be like that.
Yeah.
What inspires me is people who haven't had a sarcoma or a brother or sister with a sarcoma that just bring such relentless tenacity and drive and vision and passion to the research. That, I mean, I look at people like that and I say, shoot, I got to up my game.
Yeah.
Because these guys, man, they're killing it. And you know, I say, oh, I got all this passion. Like, okay, well, you know, look down the road at these people who haven't been touched by these diseases, and yet they are bringing it every single day. I find that just astounding and wonderful.
It is. It truly is. I know that you said that's what's truly inspiring, and I completely agree with you. I think it's so interesting that there's a lot of people who don't know what to say if they aren't kind of in the cancer world or or if they're not on the cancer channel, as my mom and I like to refer it to. But a lot of cancer patients are like, you're so, people say to them, you're so brave, you're so inspiring. And I'm like, I'm getting stoned and sitting on the couch and eating Cheez-Its and following my doctor's orders. It's the people who are working.
Wait, the doctor's orders were not to sit on the couch and get stoned and eat Cheez-Its. She's just doing the treatment that he says, and what she does as an adult, and as long as she's not like inhaling stuff is okay. Just don't want to get him in trouble. Dr. Fetterman said I should eat Cheez-Its.
No. No, he said that if I felt hungry and I wanted ice cream, to just eat the ice cream.
Yeah.
So
I mean, to be fair, I don't think the literature is completely clear on the role of Cheez-Its.
Right.
So
but it should be more clear, because Cheez-Its clearly are a cure-all. But honestly, I forgot my point now. We had a point. You were going in a direction of.
This broadcast is brought to you by Cheez-Its. No.
We're talking about people telling you were brave and inspiring. Which
she's just surviving. She's just doing what anybody else would do in these circumstances. This is the path she's on right now. She wants to live. So this is.
And that's not to say that we aren't inspiring at some points. Like you turned your diagnosis into your career, which you have excelled at, and, not to stroke your ego, but you are, a legend in the osteosarcoma community, especially in terms of the MIB sphere. And I feel like MIB's main purpose is to raise awareness and to raise funds for research. And the more awareness we have, the more inspiring people we're going to be able to find. And so that was kind of my main blabbering point.
Being a cancer patient's hard. It's not being heroic. It's survival. And I'm deeply touched by the fact that you understand what they're going through. Mia is awesome. At a point where she's, chemo resistant and immunotherapy didn't work.
Yeah.
And she's debating about whether or not to go into a clinical trial that they think will only give her a little bit more time to live versus curative. And she's actually thinking about doing it to be a data point for research.
That pushes research forward. That is my main.
The big debate that we're having in our house is if, at what point do you say,
I'm good? At what point do you say,
I don't want to lose my hair again? The cancer's spread throughout my body. It's just.
And I'm very lucky because I'm being treated at UCLA, and they've done an incredible job at keeping me alive. They really, really have. I've had like 3 brushes with death in the past year and a half, and they have kept me going. They have given me drugs that have prolonged my life. They have caught crazy side effects that they didn't expect. They keep me, up with my scans. I have an incredible interventional radiologist, and he freezes most of my lung tumors, which is incredible. It's a same day outpatient procedure. You just go in, get a couple lung tumors frozen, have lunch after your first x-ray, and then go home 2 hours later.
Yeah.
I mean, it's pretty convenient. And the fact that I'm still alive because of that is incredible. And I think research is the key, as we were talking about earlier, 100%. And that looking into more experimental treatments, like I know cryogenic ablation is relatively new to the field of osteosarcoma. But I think that looking into that is always something that's valuable. I mean, I've had bone tumors in my scapula. The spine thing didn't end up being osteo, but I did have something in my
scapula, sacrum, femoral hip, iliac crest.
Those were all ablated and fully taken care of.
Oh, tell him what you and Jasmine said to Dr. Fetterman.
You might appreciate this. Dr. Fetterman, I adore him. He is not only a great doctor, but I consider him a great friend, which is what I said in my MIB speech at Factor while I was introducing him. But I was with another patient of his who's a great friend of mine, and we were in Vegas together. She's also an above knee amputee. And we were in a bar in Vegas, incredibly drunk. Both of us over 21, clarifying. Both of us over 21. And we, at 11 p.m., sent him a video of us singing Living on a Prayer in a bar.
That is fantastic.
And both of us are still in treatment, and we're just
that's
but I feel like that kind of
he appreciated the humor in it.
You have to
Nice.
find humor in darkness.
Yeah.
Yes.
Otherwise it'll only get darker. And I think that's just the tease. So I'm just gonna say we're just about out of time. So thanks for tuning in to osTEAo, the Osteosarcoma podcast. Be sure to follow MIB agents on social media at the links in the description for all of the intel. Thank you so much to Dr. Weiss.
Thank
You are an icon for speaking with us today. And we are your co-hosts, Mia
and Serena.
And until next time, that is the tea.